Hi, thanks so much for your interest in Phases Clinic. I'm Vanessa Weiland. I'm a nurse practitioner, a clinical hypnotherapist, and a Menopause Society Certified Practitioner. Hopefully, soon I won't just be any nurse practitioner, I'll be your nurse practitioner. So, Phases Clinic specializes in evidence based and compassionate menopause care, sexual wellness, and hypermobility care. So, I wanted to talk a little bit about my personal background. I studied neuroscience and actually worked in research for a couple years, which has been very helpful in menopause care. There's not a ton of research, and I often have to kind of sift through things to decide what really is the evidence-based practice. And the same goes for hypermobility care. I decided that I wanted to work again with humans, so I went back to school for my bachelor's in nursing and master's in nursing. I studied adult gerontology primary care, and that's for the most part where I worked was in with older adults and wasn't helping a ton of people through the menopause transition for the most part. My patients were through that. And at that point, I had maybe a 1 hour lecture in menopause in my nursing program, and I thought that was probably enough, only to listen to a menopause specialist on a podcast on the way to work one day. And I had this eureka moment because she really went through a lot of the less common symptoms that can really impact someone's quality of life. And I realized that I was going to be just as confused as anyone else when and if I go through a lot of these symptoms. So it really lit a fire under me, and I decided to complete additional training in menopause management, hormone therapy, clinical hypnotherapy. And then I got board certified with the Menopause Society, and I opened Phases Clinic so that I could really specialize in this day in and day out. So I think that I really glommed onto this area of healthcare with menopause care because of my personal experience with Ehlers-Danlos Syndrome. So that is a connective tissue disorder where you have abnormal collagen, and it can lead to overly loose joints, which can actually cause downstream effects like chronic pain and other issues. And so I started having back pain when I was 13, and I went to see my pediatrician about it. And she was not only dismissive, but actually really nasty. And it really threw me off. And I actually, for the next 20 years, didn't even put that I was in pain on any of my medical intake forms, despite the fact that I was in pain every day, because I was thinking, well, this is just my normal amount of pain today. There isn't anything to do about it. And so it wasn't until my 30s that I really started exploring the cause of my pain again. And granted, I had and have a really good primary care provider who was really thoughtful and willing to do different workup and send me to specialists, but I still wasn't getting any answers or significant relief until I actually discovered on my own that a lot of my symptoms aligned with Ehlers-Danlos syndrome and was finally able to get a diagnosis at age 38. So a full 25 years after my symptoms started. So I think with menopause care, not only are you having the dismissal experience that I had where people just aren't listening, but you're also getting a lot of the second experience I had where your provider might be perfectly well intentioned, but just isn't very well educated in this. And both of those can lead to a lot of harm. So you might think that that hour lecture I got in nursing school was unusual, but actually is pretty typical. So one study of new primary care providers and OBGYNs found that only 7% felt that they had been properly trained and felt prepared to help care for their menopausal patients. And part of this is that when OBGYNs are in their training, actually only a third of them have any designated menopause curriculum. That could even just be reading. It's not necessarily a clinical experience. So what you're finding out there is that it's basically the blind leading the blind. And I do think that's changing, and I'm trying to be a part of that change. But a lot of my patients have already sought care through these channels and aren't getting the help that they need. So since specializing in menopause and sexual wellness and now hypermobility, I'm having the most amazing experiences. And that initial visit just really finally having someone to listen to them and believe them. But then after the course of working together for a few months, really helping people get back to feeling like themselves again. There aren't a whole lot of places in healthcare where you get to experience that. So it's been really rewarding. So you might be wondering, what if I'm not in menopause or perimenopause, or I'm not sure if I'm in that? And there's a lot of other areas of expertise that I have. So the main one would be sexual wellness, which would be things like changes in your libido, changes in your sensation. We do have medical treatments for those things. And then I also work closely with other practitioners in the area. And then other issues that are related to your reproductive hormones, but aren't specifically due to perimenopause, maybe polycystic ovary syndrome, really severe PMS, maybe difficulty in the postpartum period, and hair loss related to changing hormones. So all of those are areas where I can help regardless of where you're at. But I would say that my biggest area of genius or expertise would be if you're dealing with changes in previously stable situation because of perimenopause, if that makes sense. And the same goes for Ehlers-Danlos Syndrome, hypermobility spectrum disorder, or related disorders like mast cell activation and dysautonomia. I know for a lot of you, that's just a lot of mumbo jumbo, but for the patients that are experiencing that, they know that it can be really hard to find someone to diagnose and properly manage those syndromes. And that's an area where I've really grown in the last year and would be happy to help anybody, but I really think my area of expertise is perfect for those that are dealing with changes in their symptoms in the midst of perimenopause or in the midst of low testosterone, something like that. So imagine that you are catching your stride in your adulthood, maybe you're in your 30s and you finally feel like you're kind of figuring out your career, maybe your own self-care or your primary partnership. And so you say, okay, I'm up for something new. So you become a parent, or maybe you begin caring for aging parents, or maybe you ask for more responsibility at work. And you have more balls in the air now, but you're still juggling things okay. And then all of a sudden, here comes perimenopause, and you've got 1,000 balls flying at you where you're waking up at 3 a.m. every night. You have wild swings in your mood. You're snapping at your family. You have itching all over the place. It's like all of a sudden, you can't keep those balls in the air because there's just too much happening at once. And a lot of my patients have really gotten this messaging that there's something they're doing wrong, but it's not you, it's your hormones. So the basics of menopause, just so we're all on the same page, menopause is actually just one day in your life. It's the day you go 12 months without a period. Of course, a lot of people aren't having periods for one reason or another, but that's usually how it's defined. And it's normal to go through menopause anywhere from 45 to 54. The average age is somewhere like 51, 52. So if you go fully through menopause by the age of 45, that's considered early. If you're fully through menopause by the age of 40, that's a different medical diagnosis called premature ovarian insufficiency. And in either case, it's something we should definitely be looking into or ruling out because it comes with some major medical issues. And then if you go into menopause beyond age 54, that's considered late. And then perimenopause is basically any time leading up to that menopause date where you are noticing symptoms relating to your fluctuating hormones. So that could be a blip for some people. For others, it's 10, 12, even 15 years. So it's just one of those unfair things in life. And then postmenopause is kind of the technical term for the rest of your life. After menopause, a lot of symptoms get better, others might not. So since I mentioned that perimenopause can last 5 or 10 years on average, and it's normal to go through menopause by age 45, you can see that it's really not uncommon to start having perimenopause symptoms in your 30s, even if you're still having regular periods. So the main thing that's changing as you reach menopause and your supply of eggs is going down in your ovaries is that it's throwing off your estrogen and progesterone. Now, testosterone's going down too, but that's not strictly related to your ovaries and your egg supply. It's just kind of coincidentally getting lower around the same time. So earlier in life, if you are cycling, you know that your mood goes up and down, or your symptoms might go up and down as your menstrual cycle moves along. So maybe the first half of the cycle, you're doing pretty well as your estrogen is going up, and then the estrogen drops off and progesterone goes up, and a lot of people have more moodiness or PMS. So we all know that cycles come and go, but more or less we kind of know what to predict at least. And this is due to the relationship between the eggs and our ovaries signaling to our brain and back and forth and back and forth. So it's just like an ongoing cycle. But as you have less eggs in your ovaries, they're not able to send the signal to the brain anymore. So the brain says, what's going on? And it cranks things up to 11. And then maybe the next month you actually release 2 eggs. And twin pregnancies are actually more common in perimenopause for that reason. So you're going from these predictable ups and downs to major chaos, higher highs, lower lows, shorter periods, longer periods. And of course, there's a lot of symptoms that can come along with all that chaos. So one of the top mistakes that basically I was taught in nursing school, a lot of patients and providers alike will think that menopause is really mostly about hot flashes. And of course, that's a really big symptom, but we have estrogen, progesterone, testosterone receptors from our hair follicles all the way down to our toes. So we can have symptoms from head to toe. I've heard basically all of these, a lot of new pain, nerve issues, dryness, itching, a lot of mood changes, especially early on. You might have anxiety, and then a lot of difficulty both falling and staying asleep, weight change, digestive change. Basically, you name it, you got it. I was recently giving this talk for a mixed group, and a man said, I think I have menopause. So I know that probably most of you can relate. There was a survey I really enjoyed that asked women in perimenopause, would you say that you don't feel like yourself? And 2/3 of them said, I just don't feel like myself at least half the time. So although that's not the most actionable survey item, I think it's really helpful because a lot of us, like I said, are kind of given this messaging that it's like all in our heads, everything's fine, our labs are fine, when this is really happening and it's a dramatic change. It's just as big of a change as puberty was, and we all remember how that went. So Annie is a 47-year-old woman. She has a history of sleep apnea and irritable bowel syndrome. Of course, this isn't her real name. And she's telling me the last 6 to 12 months, she's having a lot more hair loss, weight gain. She's not just anxiety, but feeling really overwhelmed. Fatigue, hot flashes, body aches all over. She's still having regular periods. So although she talked to her primary care provider about all this, they weren't really thinking about perimenopause or menopause. So they ordered an antidepressant and she did try it, but it gave her nausea, so she quit it. And she's not been using her sleep apnea machine, her CPAP, unfortunately. So in Andy's case, of course, I'm going to be thinking about other causes for her symptoms like vitamin deficiency, thyroid issue, autoimmune disease causing body pain. But assuming all that turns out normal, I'm really going to be thinking about treating her for perimenopause, despite the fact that she's still having normal periods. So I will tell you why. So the menopause rating scale, this is a validated measurement used oftentimes in research, and it goes through some of the 11 most common menopause symptoms. So this is a great one anyone can print out even for their next primary care visit, because if your primary says, oh, I've never heard of anxiety being related to menopause or joint pain being related to menopause, you can show them this validated measurement that disagrees. So you can see that poor Annie is just lighting this thing up. So although I'm not naive enough to think she only needs hormone therapy to feel better, I think there's a decent chance that this one treatment could help for a lot of her symptoms. So I mentioned hormone therapy just now, and I want to make it clear that that's not the only thing I do in my clinic. I have patients that are not a candidate for hormone therapy, and I'm familiar with how to treat in that case as well, and you'll see some options later. But a lot of times I see that people have already dismissed hormone therapy out of hand, maybe because of something they've heard. And there's a lot of misinformation around hormone therapy, even amongst providers. So I wanted to briefly discuss that. And hormone therapy was one of the most commonly prescribed medications in the 1990s. I've seen estimates as high as 42% for women in perimenopause or menopause. And then you can see in 2002, something dramatic happened and the rates went down to less than 5%. And it's actually about the same still nowadays. So what happened was a study came out, and actually before it was published, there was this press conference about the findings. And they said, we have stopped the study early because we were finding more heart attacks in the group using hormone therapy. And by the way, we think it also causes more breast cancer. And that was really controversial even then, because that finding wasn't statistically significant. So you're really not supposed to report it as a true finding in that case. But in any case, the heart disease risk was true. They were finding more heart attacks in this group. So the big issue with that study, it's kind of been picked apart now, and a lot of it's been walked back because they enrolled women anywhere from 50 to 79. And the group that was having more heart attacks was actually only the 70 to 79-year-olds. And most amazingly, the women that were 50 to 59 actually had less heart attacks. It was protecting them from heart disease. So this thing has really gotten all turned around, but basically that press conference really scared a lot of people. And that was when a lot of primary care providers or other providers stopped prescribing it. And also when schools stopped teaching how to prescribe it. So that's how we got in the situation we're in today, more than 20 years later. And at the same time, of course, we're all living longer and longer. And so now women spend about 40% of their lives post-menopause on average. So I think most of us want to not just live longer, but have higher quality of life for that time as well. And I think that more likely than not, hormone therapy is going to be a big piece of that for those of us that can take it. So just to really drive it home, this is the rates of breast cancer since 2002. And you can see that big drop in hormone therapy use did not come with a big drop in breast cancer rates. So we really, at this point, definitely don't think that estrogen causes breast cancer, because that study actually showed a lower risk of breast cancer with estrogen only. But in the group using both estrogen and some form of progesterone, which would be anybody that still has their uterus, it does seem like there's maybe about one extra case per 1,000 women who use it per year. So that should be considered. That should always be a part of the conversation. But since there's other benefits to your heart health and your bone health, and of course, treating symptoms, I think we need to be taking that all into account and shouldn't be deciding for you based on that risk of breast cancer. And interestingly, if you have a family history of breast cancer or something like that, although your baseline risk is higher, hormone therapy doesn't seem to impact that baseline risk. So another big concern that people have is around the risk of a blood clot, which is true with oral birth control. It's also true with oral hormone therapy. But interestingly, if you give the hormones through your skin like a patch or a gel, there's no increased risk of blood clot. So that's usually the way that I would start things. But once again, the risk of blood clot either way is very low. And of course, we use birth control without too much concern of that side effect. So the Menopause Society, they give us healthcare providers guidelines around hormone therapy or other menopause issues. And they, at this point, say that hormone therapy is the most effective treatment that there is for common menopause symptoms like hot flashes and genital changes. And they also say that if you start within 10 years of menopause onset, so for the average person, that's by age 61 to 62, the medical benefits outweigh the medical risks for all those reasons we just said. Now, if you're beyond 10 years, we can still talk about it because it wasn't until 20, like I mentioned, 70 plus that there was a big risk to your heart, but there's just aren't as many benefits at that point. They also say that we should be considering everyone's unique health status and having collaborative conversation around this. Like I said, I do in my clinic, but I know that that's not happening a lot of times in a primary care setting. So I promised that I would discuss briefly other options for hot flashes. There's a lot of other medical treatments that have excellent evidence to help with hot flashes, and there might be other options for other symptoms like sleep disruption or mood changes. So I have listed here the ones that are recommended by the Menopause Society, including, of course, hypnosis. So that's why I decided to get trained in hypnosis. I wanted another option for my patients that can't use hormones. And hypnosis also has really strong evidence clinically for some other things outside of hot flashes like weight management, anxiety, insomnia, which is trouble sleeping, irritable bowel syndrome. These all have guidelines that would speak to that. And then this is an area where I kind of like color outside the lines a little bit when it comes to evidence-based medicine, because I find that a lot of the areas where hypnosis is the most helpful are things that are hard to measure, like dealing with your own self-doubt or limiting beliefs, or just when you kind of get in your own way, like self-sabotage kind of thing. So I have found it really helpful as an adjunct alongside other medical management. There are two main tracks to work with me in Phases Clinic. Both of them are in a 16-week container because I find that it takes a few months of making small adjustments, whether that's hormone therapy or other medications or supplements, to find the right cocktail per se for each individual. So I want to set out that expectation from the beginning that it's going to take a few months working together. You're making that commitment to me, and I'm also making that commitment to you. So in the Vitality Reset, we're going to spend 2.5 hours together, myself or a health coach, working through the adjustments to your medications, like I mentioned, and then lifestyle coaching, and then an hour hypnotherapy session each month. So my lifestyle coaching will focus on sleep, stress, sexual wellness. We can talk through other items like longevity or hair health. It's of course very individualized, and I have a course that's going to complement each month what we're working on. If you hear sexual wellness and you're like, that doesn't apply to me, just know that that part of the course or our treatment plan is also going to help with urinary complaints that are very common. And then there's also an included suite of laboratory testing that's going to go through some of the most common causes that can kind of mimic perimenopause and menopause symptoms. Some of the things I was talking about earlier with Annie, like thyroid issues, vitamin deficiencies. And then based on what we find there, you're going to get a personalized plan of supplements that are going to help make up for any deficiencies that we found. And then you'll also get a personalized diet plan. In addition to, all these things, like I mentioned, you're going to have a course that kind of goes alongside for those 4 months that we work together. Of course, has a community as well. And then you'll have access to that forever. So this is, like I said, something really comprehensive and really designed to transform. For a lot of my patients, they feel like they have that foundation already around diet and exercise and sleep and stress management. And they're really most interested in getting their medications or perhaps their supplements sorted out. And so in that case, we're still going to work together for 4 months, but it'll be shorter visits, 60 minutes to start, and then 30 minutes each month to really get the medications, the medical plan sorted out. And we can still do laboratory testing, diagnostic testing if it makes sense, but it just wouldn't be included. So I want to talk through a few cases of where working with Phases Clinic has been helpful. So Susie, she was doing the Vitality Reset with me, and to start was having a lot of trouble with sleep and energy, and also not working standard shifts. So I think that was also throwing things off. And so we're working together, of course, on the medical management. And then I say, let's do the hypnotherapy session around things that you can do to help your sleep. And she says, well, there's something I actually wanted to discuss, which is that I'm having a bottle of wine every night. And first of all, so proud of her and so brave for her to mention that to me, because that's very vulnerable. And I said, okay, well, that's something we can work on with hypnosis as well. So we work on that. And the next time I see her, she's just looks so much more vibrant and awake and alive. And part of that was the hormone therapy helping her sleep. Part of that was that her work shift had changed. But she also tells me, by the way, I haven't had any alcohol since our last session. And to this day, she's been abstinent. So that really shows where that's not something that hormone therapy is generally going to fix on its own. So it was really the more comprehensive work together that helped on that piece. And of course, I give her all the props for, she did that on her own, but I want to take just a tiny bit of success for hoping that the hypnosis really helped her wrap her mind around why this was the best thing for her to finally take that step. So Liz is someone else that worked with me in the Vitality Reset, and we were working together with hormones. She's sleeping better, her energy's better, and she was actually really following the diet plan that we laid out together, and obviously making small tweaks here and there, but found that it was really filling and her energy was better. And so she was really interested in working out more. And so that was the main thing we were doing with hypnosis, was working on specific food triggers and also, just working on any of her internal barriers to getting to the gym. And so ultimately she has decided to still go on Ozempic to work on weight loss, but she tells me that she's already lost 10 pounds. And I'm really reassured that, adding on a weight loss medication, I know that she's going to be able to do it a lot more safely with a good nutrition plan and a good exercise plan to maintain muscle mass. So I consider that a big success. And then Jasmine, we had worked together to add estrogen and progesterone for sleep. And she was finding that her mood was doing better. She had had a really rocky year before working with me, and mood became so unstable that she actually was hospitalized for it. Luckily, everything was stable by the time she saw me, and she was working with a psychiatrist. But it wasn't until we added testosterone for her libido that she said, this was the thing that really helped me feel like myself again. And it really helped unlock that key to my anxiety that just kind of came out of nowhere. So she's working with the psychiatrist to try to de-prescribe some of the medications around mental health. So, she's still going to have ups and downs as time goes on, but that was a really great transformation that we had just with the basic Balance Essentials plan. So it's rare that someone comes to me and I'm the first person they've seen around their perimenopause or menopause symptoms. A lot of us are jumping from person to person, trying to make do with primary care or OBGYN, or maybe even seeing another someone that claims to be a menopause specialist and either isn't following evidence-based guidelines or is still misinformed on hormone therapy, or maybe is not looking at things as holistically as Phases Clinic. So I think your choices are to continue muddling through, wasting time and energy and money on unproven cures, or fast tracking your journey to reclaim your vitality through menopause. So I really hope that you will decide to take this shortcut and work with me for the next few months. After that 16-week container, I'm always happy to refer back to your primary care team. I find that oftentimes they are willing to take over on prescribing hormone therapy, even if they are wary to start it, or otherwise we can continue working together long term with a quarterly membership. So of course, finances are always a big question for folks, and I do want to be straightforward that I'm an out-of-network provider, which means that I don't bill the insurance directly, but many insurances are actually really good at reimbursement with a super bill. I just want to let you know, if you have Medicare or Medicaid, I can't provide a super bill, and that's just due to regulations on their side. But if you have an HSA or FSA card, I can also accept those directly, so that can be a big help for a lot of folks. So I imagine you probably still have some questions, and so feel free always to message us with your questions, your unique situation and challenges, and keep your eyes peeled for a FAQ video coming along as well.